Hi, sorry. As was mentioned, I'm Dan Brook. I'm an MD PhD student at Ohio State in the medical scientist training program. I'm in my 5th year, about to enter my 6th, and I'll be presenting on the ecological relationship between acute hepatitis C virus incidence and office-based buprenorphine prescribing in Ohio. A little bit of background. Ohio and nationally, we're experiencing a hepatitis C virus epidemic. Hepatitis C has now overtaken HIV as the deadliest chronic infection, both in the state and nationally. HCV is a costly and debilitating disease. One 90-day treatment for hepatitis C, which has about a 99% cure rate with with the majority of the strains, is between $25,000 and $100,000, depending on your insurance. And for those who aren't treated immediately, over about a 20-year period, some develop cirrhosis and hepatocellular carcinoma, of which the only treatment is a costly liver transplant. HCV is primarily spread through shared injection drug equipment. Many of you probably aware of the opioid epidemic, and a majority of injection drug use is conducted by people with opioid use disorder. Buprenorphine is a medication for opioid use disorder. And in some studies, it and its group of drugs known as opioid agonist therapies, so they work on the opioid receptor, may prevent incident hepatitis C through an indirect mechanism, similarly to how you can think about Nicorette reducing lung cancer by reducing an individual's craving to inject drugs, to inject heroin or other forms of opioids. They reduce their sharing of the injection drug equipment and therefore reduce the spread of hepatitis C. However, buprenorphine can only be prescribed in office-based settings after a special 8-hour training, which gives the provider an X waiver to prescribe buprenorphine in certain number of patients. And counties around the state might be increasing office-based buprenorphine prescribing to slow their individual HCV epidemics. So here's a theoretical model, which in epidemiology we call a directed acyclic graph, to think about this relationship. The exposure here is acute HCV rate in 2015 at the county level. And a physician in 2017 may become aware of their acute HCV rate in their county in 2017 because of the 2-year lag in publishing hepatitis C virus data. The physician might then end up getting the buprenorphine waiver because of the relationship between hepatitis C and opioid use disorder. And then in 2018, that physician might begin to prescribe buprenorphine. Now, when I say physician, this was, again, in 2017. Buprenorphine has since been expanded to other healthcare providers, but before that time was just physicians. So a thing that can confound this relationship or mix up the effects between the exposure acute hepatitis C virus and physicians prescribing buprenorphine is the total hepatitis C virus rate. So in Ohio, we categorize hepatitis C as acute or total, which is acute and chronic hepatitis C. The years 2014 and 2015 I'm using to adjust my model to account for the confounding of that factor. And then another potential confounder that could affect this relationship is the opioid overdose rate from 2010 to 2015. So the overall aim is to describe the ecological relationship between county-level acute HCV in 2015 and office-based buprenorphine prescribing in 2018. The hypothesis being that higher HCV rates are associated with a higher office-based buprenorphine prescribing. Theoretically, these physicians are seeing the HCV rates in their county and then reacting to it. Data sources for the model, we had buprenorphine prescribing data provided to us by the Ohio Mental Health and Addiction Services. HCV and unintentional drug overdose death data was collected by from the Ohio Department of Health, and county population was gathered from the US Census. The exposure, again, is the acute HCV rate by county in 2015. The outcome is county-level office-based buprenorphine prescribing in 2018. The model that I used was a multivariable negative binomial regression model. And the adjustment set is the acute HCV rate of the prior year, 2014, the total HCV rate in 2014 and 2015, the unintentional drug overdose deaths, 2010 to 2015, the county population size, and then the office-based buprenorphine prescribing capacity. So those who potentially could prescribe buprenorphine, not all of them were. So here in table 1, I have the summary statistics. You can see that from 2014 to 2015, the acute hepatitis C virus rate per 100,000 population increased from the median county level was 0.4 to 0.6. There was a similar increase in the total HCV rate, which again is the acute rate, and the chronic rate. I can go into more specific details if you have questions about that after the presentation, but that increased from 97.4 per 100,000 to 125. And you can see in the county level office-based buprenorphine capacity per 1,000 population at the county level, the median was about 6.78 spots per 1,000 people. And then the actual prescribing of that was a little less at about 5 per 1,000 people. The county level age-adjusted unintentional drug overdose death rate per 100,000 person years was about 17, the median for counties in Ohio. So here is the model. If we look at the crude incidence rate ratio of the negative binomial regression model, we see that using acute HCV rate per 100,000 population to predict office-based buprenorphine prescribing in 2018, there was about, for every 1 unit increase in the HCV rate per 100,000 population, there was about an 8% increase in the office-based buprenorphine prescribing in 2018. Adjusting for the confounders in our model, we saw an attenuation of that relationship. So a 1 unit increase in acute HCV rate per 100,000 population in 2015 led to about a 4% increase in the office-based buprenorphine prescribing in 2018. And it's to note that this relationship is not statistically significant. So county level acute HCV rate in 2015 does not appear to be meaningfully associated with office-based buprenorphine prescribing in 2018. So what does this mean for the state of Ohio and the health of Ohio? Is that counties may not be sufficiently reacting to the HCV epidemic by increasing office-based buprenorphine prescribing. Again, if we get back to the analogy with tobacco use and lung cancer, theoretically counties with really high lung cancer would be prescribing more Nicorette to reduce cravings to use cigarettes. And theoretically, that's the same relationship with this. Some limitations are surveillance data, which has biases in reporting, measurement, and selection. This is ecological data, so a physician does not necessarily, in this model, react to the HCV rate and then prescribe. It's more on the county level. And we have a low sample size with less than 88 counties. And some of the acute HCV data is potentially missing. It's labeled as 0, but we're really unsure if it's actually 0. So in conclusion, increasing acute HCV in 2015 was not meaningfully associated with higher buprenorphine prescribing in 2018 in Ohio. Next steps are to do a sensitivity analysis, assess the preventive relationship between office-based buprenorphine prescribing and HCV. And I'd like to thank my teammates and my funders and you all for being here. So here's the overall conclusion and the model. So you can refer to it if you have any questions.
Thank you so much, Dan. Very interesting. So again, anybody in the audience, you can either open up your microphone for questions or put your question in the chat box. And I guess I will go ahead and start off with the first question. One of your conclusions was that maybe the offices aren't prescribing enough buprenorphine. What other implications do you think there would be for physicians based on your work here?
Well, there's kind of two different ways I think that you can look at this relationship. You can look at it as physicians who have the waiver are not prescribing enough, but you can also look at it as maybe physicians are not even aware of how to prescribe buprenorphine or its effectiveness. And I think even just getting more physicians in the door to get the buprenorphine training, that X-waiver training, can increase people's awareness, reduce stigma around prescribing buprenorphine and treating patients with opioid use disorder. So kind of like with the stages of change, I think maybe this is just one informative step towards like a next step in the stages of change for physicians in Ohio.
Thank you. Does anybody else have any questions? Dan, you did mention a few other steps that you would like to do. Do you think you would be able to do them within your time as a student? Or are these projects for maybe some of the colleagues that you had mentioned?
Uh, so I am hoping to do the quantitative bias analysis or the sensitivity analysis. My main concern is about the acute hepatitis C virus rate, and that's a really interesting public health problem, specifically in Ohio because we're a home rule state. So a lot of the counties have quote unquote zero acute hepatitis C in their county. And so it begs the question, do they actually have no acute hepatitis C, or did the counties not have the funding to actually test the patients for acute hepatitis C? So they're just then categorized as like total hepatitis C. And so I want to vary that number to see where I can get it to actually change the model relationship to make it a significant relationship, and see if these numbers are wrong, what is too wrong to make this relationship in the direction we think it should be, or think we hypothesized it would be. And then the other next step is the preventive relationship between buprenorphine prescribing and HCV. And that's the overarching theme of my dissertation. So hopefully within the next year or two, I'll be able to answer some of those questions in three different aims.
So what are you doing for your dissertation then?
So essentially, I'm trying to flip this relationship. So this model, flip this relationship on its head. The idea being that I'm looking at actually, if physicians are prescribing, say, buprenorphine in 2010, does that reduce the acute HCV rate in 2015? So the problem is that acute HCV data is lagged to the point where I can't actually study the preventive effect of this for several years because of the lag in publishing the data and the theoretical lag in how this would act preventatively. So it could take a year or 2 years before a physician prescribing buprenorphine to an individual or population actually reduces the hepatitis C in that population.
Or as you had said before, having a number of a number of physicians actually trained to be able to prescribe.
Yeah.
So,
Yeah.
okay. Again, for the audience, any questions? Feel welcome to open up your microphone or put a question in the chat box. All right, one more question for you, Dan. When you graduate with your MD and MPH and your PhD, what residency do you hope to do, and what do you plan to do for your future career?
So right now I'm thinking of joining or applying to PSTPs, the Physician Scientist Training Programs, which are an internal medicine fast track program. I'm looking at several of those, probably infectious disease. I don't know. I still have like 2 years left of clinical training to get my feet wet in all the different specialties to see if that's the best fit for me. But as of now, I love studying infectious disease epidemiology. I love all of the ways that it can integrate all the other specialties within internal medicine in public health. And so I think that's where I'm leaning towards, infectious disease specialty.
Excellent. And I think your career is off to a great start with some of this kind of research that you're providing, and some of the critical thinking and the questions that you're providing as well. Thank you.